I want you guys to meet Gene. Gene is 82 years old, and there's that dreaded report of altered mental status, like whatever that means. Encephalopathic secondary to what? The medic doesn't really know. You get handed a chart, and it's full of a bunch of old stuff, new stuff. But you start to, really go through things in real time, right? So that's what's happening. She's coming from a nursing home. We know there's a history of CKD. We see that on the chart. She has AFib, and she's taking warfarin. There was a doctor at the clinic that had ordered some labs. You actually see that INR was elevated that nobody told you about, so almost like sub 4, like 3.8. And then also the creatinine's elevated, which is, of course, a well-known. So there's three, failures that actually occur that we've kind of highlighted over here that happen in real time. First and foremost, people talk about the ABCs and they put G at the bottom of just like glucose or whatever like letter you want to use. Still, like up to 30% of these are delayed and actually not even obtained, which is crazy. So like 15 seconds, it ends up being like a 15 to 20 minute intervention. A lot of that is because like for me, I'm getting this story. I'm trying to again like synthesize this information. I sit back at the desk, one thing or another. I'm on the phone. Someone's calling me. It's a family member. I'm actually trying to go through this in real time to figure out like why she's even here. And it's like, oh, shoot, retrospectively, I've missed this. This is just what happens, unfortunately, with some of these patients. Drug to disease mismatches. The INR is elevated. Again, I was highlighting that point. Sometimes that it really does slip through the cracks. Those INRs aren't checked. There's antibiotics that are selected that I'm not actually adjusting for, given what's actually occurring with this patient. And this is a potential and preventable risk of drug toxicity, and that actually will actually work, go to worsening outcomes. Documentation burden as well. So now it's starting to kind of pile of what's happening and the complexity of this patient. So initially it's like you're trying to triage of like encephalopathy. I find out she's septic. I have to choose these things. I'm going down different pathways. But that all kind of comes together. This anticoagulation, that elevated INR, all I'm trying to do simultaneously and create a note while I'm actually managing the patient. So instead of having all that chaos, here's like kind of the flip. And when Sayvant and BMJ together can catch these things in real time. So, addressing these points, going through prioritized diagnostic prompts. So like whenever someone actually hits the floor, we've got these heuristics that are set in place for high risk presentations that will prompt you, remind you, maybe it's 4 a.m., maybe I'm tired, maybe I've seen already 2.2 patients an hour, and I maybe forgot to get the glucose. That's keyed up and ready to go. A reminder as well about the CKD, about the issues that can happen with nephrotoxicity, with issues of the agents that I select and choose for this patient, trying to provide care, but again, sometimes those things just kind of fall through the cracks. In the third point as well is like really trying to bring that synthesis together of my rationale with documentation. So it's not just a point of me making a billing receipt. It's me actually going through my clinical thought patterns and having that reflected within my documentation and actually hitting high levels of evidence, of course, with our partnership here with BMJ. So I want to show you guys the interface of what actually exists. On that left-hand side, you'll see these columns of your patient selections. In the center, you'll see a summary of that conversation. This is after, of course, like engaging with this platform. Right here in the middle, there's this summary box though with that intelligence. So the SNOMED code strikes for triggers, the BMJ clinical intelligence for things like stroke, for altered mental status. They actually rank these differentials. Intracranial hemorrhage, of course, with the elevated INR. A TIA gets flagged. There's the more moderate risk as well based on that patient presentation. And this is not just a generic list of things. It's not just yet another like a laundry list of stuff. These are actionable items that are bespoke to that patient encounter. So again, like the key point here, not a generic alert. This is something that actually is occurring, this evidence ranked clinical intelligence that's specific to this patient's presentation. Okay, it's not just me just throwing things up.
So what's happening here, just to summarize, is that we're actually helping Andrew in his practice in bringing up the relevant clinical evidence on the risk factors that are associated with this particular patient and what they're going through within their visit, right? I think that's a really key part of how we're trying to help shorten the visits and also give the right information for the patient at the right point in time.
Yeah, and as a physician, that's very exciting for me. This lives in my phone. Right, so whenever I leave that patient room, I can reference that. I can look at that. And again, trying to help with that cognitive burden because, I'm synthesizing numerous things, numerous points of information, but putting this together in something that's coherent, it actually helps.